You're anesthetizing a patient with elevated intracranial pressure, and you want to avoid cerebral ischemia. What are the elements of intracranial pressure, and what can you do to control them? This graph shows how initial changes in intracranial volume are initially compensated, mostly by displacement of CSF and venous blood. Eventually, an inflection point is reached, and increases in intracranial volume quickly cause the pressure to rise. Changes in ICP are critical because they can decrease cerebral perfusion pressure, which is usually equal to mean arterial pressure minus the ICP. Eventually, elevations in ICP become catastrophic and the brain will herniate. Herniation can occur as subfalcine, uncal, cerebellar, or transcalvarial. So what makes the intracranial contents? It's easiest to think of it as four components: cells, CSF, fluid, and blood. The cellular compartment may have increased volume due to mass lesions such as tumors and hematoma. The neurosurgeon is best able to intervene with either resection of the mass or evacuation of clot. The CSF compartment can be manipulated with drainage. In some cases, spinal fluid can be drained from a lateral ventricle by passing a needle into it. In other cases, a lumbar drain may be helpful. Brain edema is an important cause of increased intracranial volume in many patients. The blood compartment is made up of arterial and venous pools. Improving venous drainage is critical when attempting to reduce ICP or improve surgical conditions. The keys to allowing good venous drainage include head-up posture, neutral head positioning, no circumferential neck pressure, and minimizing intrathoracic pressure. A patient who strains or coughs can be catastrophic. Vasoactive agents and anesthetics are at your disposal. Changes in PaO2 and the PaCO2 affect cerebral artery autoregulation, which controls blood flow across a range of mean arterial pressures. Derangements in autoregulation can be accounted for by the anesthesiologist in order to ensure adequate brain perfusion.